Welcome, Terri Nishimoto, to this awesome interview. And she is a mind body informed physical therapist. We met at a mind body practitioners conference actually in Boulder, Colorado. And I'm so glad we get to have a conversation for the women who are listening, who are experiencing pelvic floor symptoms and have questions about hormones and other things that are female specific. So thank you for having the conversation with us.
Great. It's great to be here, and thank you for inviting me.
No, of course. Let's actually just dive straight into this first question, though, of yourself, though, in your own journey. Terri, can you tell us about what brought you to being a PT in the pelvic health area, or you being
Yes.
recovery coach and all that?
I can make it a long story, but I'm going to make it kind of short. Like a lot of pelvic health physical therapists, they have their own pelvic issues.
Mm.
I had been a PT for a while and then became pregnant, and during pregnancy developed a prolapse. And at that time, there wasn't that much known about pelvic physical therapy, and so that's when I realized, okay, this is my passion, and this is what I'm going to do work with. And I feel like I still love it and I love it, but I always felt there was something missing. And patients would get better, they'd be able to manage their symptoms better, but I really felt, again, we'll use this word a lot, the root cause was never really addressed. And so then I got introduced to Dr. Schumer, as you know, took courses from him, and it just started to open up the whole world. And now did training in pain reprocessing and emotional awareness and expression therapy. And it's just provided so much more reward in helping individuals, both male and female, with pelvic pain.
That's incredible.
And so now it's a new message, it's a new paradigm. It's great to be part of the paradigm shift.
Yeah,
So
that's so interesting. And also,
yeah.
when I started initially doing this work at more of a practitioner level in 2020 with Dr. Brianne Grogan, she also went through a prolapse during her pregnancy. She's a pelvic health focused physical therapist, but our original program is a little bit more physical therapy driven. And as I learned more about Schubiner and others, I'm like, whoa, I knew the mind body connection mattered, but we were kind of putting it on the back burner. We're like, hey, definitely you need to release the pelvic floor. There's hypertonicity. We need to do these particular exercises and then rebuild it and create that mobility and stability. And the musculoskeletal system matters. But then it's like, oh, also maybe like stress, make sure you meditate and do a couple. But like, no, 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 bring that to the
Exactly.
forefront. That's what is a
Right.
primary driver of the issues typically, and also take care of the body. So I like the combination of both really well.
Right. That top down and bottom up approach is really
And side to
key,
side.
and side to side, all around.
Yeah.
Yeah.
Um, just wondering about, mind body symptoms. Everyone, of course, deals with neuroplastic symptoms. Everyone sometimes has headaches or stomach aches or pains. Like that's what it is. It's the brain and nervous system creating a message in something for us to be aware of. Have you had any kind of major issues or something that you're like, wow, I went through that, but then I was able to resolve it? I was just curious.
Oh, yeah. Thank you. Well, the prolapse, I think, was definitely purely, it was traumatic in that my body wasn't the same. But then I had a really horrifying experience where I ruptured a disc in my back. I don't know if I told you that before,
Mhm.
and had the burning pain down my leg and wasn't able to work. I did quote yoga with my daughter, and but also at the same time having a really stressful experience with a business that I was involved with. And now that I look back, it was real, I tell people who don't understand my body, it was yoga and me not paying attention to my body. But really, when I look back, it was really the nervous system upregulation. And then my MRI is pretty involved. So I always joke my goal in life is to have the worst looking MRI and not have many symptoms and live my
Oh, yeah.
life and not need surgery. And that's where I'm at. And same with people who have had pelvic issues and different pelvic studies that may show something, but it doesn't necessarily mean that's the cause of their pain, right?
Let's
So,
actually jump straight there then, because I get these questions all the time, right? As people learn about neuroplastic symptoms, mind body syndrome,
mhm.
TMS, that whole world, they're like, okay, but I did injure my tailbone. I ruptured my tailbone 8 years ago. Or I have this specific thing that, like, it really is structural and they're trying to suss it out. How much of that is influencing their symptoms versus it just being mind body, like penile neuralgia and other potential things that they might be experiencing? what sort of direction do you have for them? Because, the ruptured disc story, someone might be like, well, my gosh, that's definitely structural. So that probably caused your pain. But also, I'd love to hear about that.
Yes, yes. And I often use the huge study that showed that asymptomatic um, individuals had MRIs, and it's just a part of aging. We even call it, degenerative changes, bulges, and sometimes ruptures is just part of aging, the aging process, like getting gray hair and a tailbone. And what can happen is that it can start with an acute injury like a tailbone or a back injury or UTI that is a real UTI or a yeast infection. But what can happen is that our bodies do heal. And so if the healing takes longer than that standard 3 to 3 months, then we need to look at other factors because pain, especially chronic pain, is not a single cause. There are much more. It's much more of an orchestration of different things, but the director or the conductor tends to be the brain.
That is a
So
beautiful metaphor.
yeah,
That's awesome.
yeah.
That's so well said. Um, so about kind of the topic I mentioned earlier, I'm wondering how much do hormones affect pelvic pain or maybe other pelvic floor conditions that women might be experiencing?
Yes, that's a great question. And I'll get that as well, aside from the structural questions, well, I have PCOS, or well, I have endometriosis, or I was fine until I went through perimenopause. So hormones, the short answer is yes, hormones do affect pelvic pain, but again, it's not the single cause. So, but it can affect it, and we need to be mindful and bring it into the picture, just like diet can be affect pelvic pain, just like lack of movement or movement can affect all chronic pain. I'm saying pelvic, but it could be any pain. And so when we look at hormones, I feel we need to look at why women tend to get labeled as, oh, fibromyalgia real quickly or autoimmune. And I think that's also something to be mindful of as well, because it's a fact that more women have autoimmune disease and chronic health issues.
Yeah.
And that can be maybe women historically and culturally have been labeled as the weaker sex, or they tend to put other people's needs before their own. And women do tend to statistically have more traumatic experiences and tend to have PTSD experiences. So it's multiple factors. And I heard a great interview by Dr. Gabor Mate talking about why women have autoimmune, his feelings. He
Right.
said there were 4 reasons. And it's interesting because I think the 4 reasons interconnect. But he said, number one, women are too nice. And he felt that the reason that we learn how to repress our emotions, particularly anger. The other is they tend to put their duty and roles and responsibility before their own needs. They tend to feel responsible for other people's emotions. And as mentioned before, they tend to put other people's needs before their own, which is a very similar
Right.
people pleaser,
Yeah.
perfectionist kind of that we see with the just chronic pain
Yeah.
personality type.
And exactly. I mean, men and women do both of these things, but like you said,
Yeah.
women might have more of a tendency to take on like that motherly, maternal role. I'm
Yes.
here to take care of the family, the community.
That's my
That's
role.
beautiful. And that's a
Yeah.
like it's totally needed and we're so grateful for it. But it can come at a cost if you don't balance it with like self-love and self-care and self-compassion.
Exactly. And then my curiosity goes to what if we start teaching our daughters early and our sons, but particularly our daughters, that they don't need to be perfectionists and their needs do matter. That I wonder if in the future that discrepancy between male and female and autoimmune will be less if
No
we could
one will have
start
autoimmune
early.
diseases anymore.
Wouldn't that be awesome?
That'd be awesome.
Yeah.
I think it's great though.
Or pelvic pain.
You
Yeah.
shouldn't have to, have like a 5-year run in with chronic pelvic pain in order to discover that you should love yourself or prioritize your own needs. I
Your
mean,
own needs.
ideally, culture and society and schooling like involves these this information. So a lot of things do need to change, clearly.
Yeah. Yeah.
Um, when it comes to, the hormonal side too, I was wondering if someone's like, hey, I had some testing done, it looks like I do have hormonal imbalances, and they're considering more of a hormone-based therapy versus going to physical therapy. Or maybe they wanted to like, I'm going to do physical therapy, I'm going to like address the muscles and I want to address the endocrine system. And again, it's kind of like, let me fix the body instead of let me see some of the mind, body, mental, emotional things. Do you see that happen sometimes when you'll have a patient kind of do that and then they get some results, but not enough? And I'm wondering, because this may be really, someone would be listening and be like, that's me right now. Maybe there's something I'm not looking at. I'm not turning over all the stones.
Right. And I think it comes from the lens that you put on as you approach these issues. Like if I'm going to go through the physical therapy route and think, oh, this is going to fix my weak core, or this is going to fix my tight pelvic floor muscles, and I'm going to get hormones, it's going to fix my imbalance. There's all that messages I'm broken and I need to be fixed. So if they can look from a different lens that I'm going to remain curious and I'm going to try these things from the lens that one, I don't need fixing. I'm going to get strong because I like to be strong and it's healthy. I'm going to try these hormones because I would like to be preventative. Because now, if they're perimenopausal, they're showing how hormone therapy can not only for pain, but maybe dementia, um, depression, anxiety, osteoporosis, those other things that happen when the hormone changes during perimenopause. So again, the lens though is I'm going to be open and curious versus I have to fix this. And I feel if they can come from that top-down approach of I want my body is healthy, I can heal, I deserve this, then it will come along better. I will have patients who will do the hormone thing and then come back and say, okay, now I'm ready to try therapy from the mind body approach. And but then they're really ready. Does that make sense? So
Yeah. And so, yeah, you just see that they become ready after a failure, maybe, or
yeah,
there's not
or
really a
maybe
way
they
to
didn't get as
force them
far.
to do it
Right.
yet. Yeah.
Exactly. And then I get other patients who are afraid of hormone therapy. And so they're really ready to try everything but the hormone therapy. But I feel, again, it's that orchestration of all these different systems and figuring out the unique individual and what that unique individual responds to, with their nervous system, what works for that person's nervous system. I
Yeah.
think it's heard a lot. You meet them where they're at.
I'd love to, we can go into some specific pelvic health situations and how hormones are a component and other components, just kind of hearing you talk about it because you've helped so many patients with these things already. I think people will get a lot out of it. What about endometriosis, first of all? Like, what are
Yeah.
the notes on that?
Yeah. Endometriosis is definitely one of those muddier or better hybrid type of diagnoses because it can take 8 to 10 years for someone to finally get that diagnosis. And that's a long time for that neural pathways, right? To get scared, dismissed, worried if they'll ever recover. And the pelvic floor muscles, along with other muscles, tend to really want to protect because they haven't had any answers. So with that, with my patients with endometriosis, I'm very careful not to use words like it's in your nervous system or it's all in your head because they've heard that too. They hear that, have heard that too much. And so I have brought there is really a nice study now that looked at central sensitization, which is another word for TMS, mind body neuroplastic symptoms, where they looked at individuals who've had the surgery, and 40% of women who've had the laparoscopy surgery will end up having some sort of pain after surgery. So what they did is it's called the CSI or Central Sensitization Index that looked at the response of emotions and stress in their lives. And those who scored high, understandably, also did not do as well after surgery. So that was just one study. But now I think because women's health obviously needs more studies, and Now, what I'm hoping will happen is that if they do that test before the surgery, not after, and then we can treat these women from the mind body perspective before they have the surgery. And I can almost guarantee that the outcomes will be much better.
That's amazing. Yeah.
Yeah.
I'm wondering, because I've actually had a few people ask me this question. They're concerned about the laparoscopy. If I said it right, I tend to say that wrong, but
Well,
um,
that's perfect.
okay, yeah, that
Laparoscopy.
laparoscopy, the diagnostic surgery in order to see if they are diagnosed with endometriosis. Can you give any guidance on someone who might be on the fence? If like, maybe this is just really mind body and this is happening with my brain and nervous system. I don't really want to go in there and do the surgery. But then again, it might really be something structural here. And I don't want to be, removing myself from getting medical help. Do you have any pointers on what someone should do?
Yeah. Because again, that's a very individualized decision that is important. Because then some people will put all their eggs in that basket that the laparoscopy is going to cure me. And like I said, many of them will have pain afterwards. So that can be scary in and as itself. But I think if they have done, because there's a diet component, there's the mind psychological component, there's the physical component. They feel like they've done all of that and their pain then becomes more truly cyclical. And
Mhm.
they can really put their this is when the pain is the worst, when it's associated with the cyclical, but now the other things have kind of calmed down. Then they can look at be more comfortable with looking at the laparoscopy, as long as they find a surgeon that's skilled and is willing to listen and be a collaborative decision maker. Then I think that would be the time. The good news is the research is starting to get better, and they are looking at finding things that is not a surgical approach to diagnosing. They're going to be able to look at blood work. The MRIs and the ultrasounds are getting much more sophisticated. So, but if they still have that angst of I really don't want to, I would work with them with that and still say, well, let's keep working with your nervous system and the muscles and both approaches,
Nice.
top down, bottom up. Yeah,
That's awesome. Yeah, because there could be a lot of things. It could be intuition. There could be just the sense it's not right for your body right now.
exactly. And they need to tune in and listen to that.
Yeah, so that's a good point. What about with prenatal, postpartum? How would hormones or other components play into that, and any guidance?
Yes, I believe, because again, there's individuals who go through pregnancy and they get a lot of pain. One of the biggest culprits that they say are the hormones, particularly the relaxin hormone. That's the hormone that tends to soften all the ligaments. But studies again are showing that relaxin is not responsible for pelvic pain. So they looked at women with twins, so their relaxin is much higher. Looked at patients who did not have pain, but then had high levels of relaxin. So now, which is great, the relaxin got taken off the target list, but when they really looked deeper, it was more mind body associations for their pains. Job satisfaction. Are they sleeping? What are their stress levels like? So it's very interesting because I was on the side that, well, pregnancy was totally an exception because of everything, but it's not. So that was really
That's
interesting.
huge.
And then postpartum,
Okay.
right? Now they're a new mom, they're busy, they're not sleeping, they may be returning to work. So many other factors can be causing their pains, but also hormonally we can't ignore them, but we can put them kind of on equal play with all the other factors as well, all
Wow.
the other different parts of the orchestra. With the well, I'll talk about perimenopause. There's only one exception that I say hormones are important, and that is the topical hormones in the perineal area during perimenopause. That is one time I do say that the lack of estrogen and even testosterone in that area for this for the health of the tissues, that is one thing that can help kind of genital urinary symptoms during perimenopause is a topical hormone, in addition to everything else. But that's one time I do say hormones are important.
Okay, so that can be helpful. And for
Yes.
some, they might just be producing enough though, even during perimenopause. potentially due to their environmental factors, what they're eating, or like it seems would every human being, would every woman need that at that stage of their life, some addition, or does it depend on a lot of factors on how much they're producing internally?
Yes. As during perimenopause, when they are still having cycles, then it is just an individual decision. But after menopause, after perimenopause and they are menopausal, they are no longer have any hormones coming from the uterus, then I would be more strongly recommending topical hormones for the area. There's a diagnosis called GUSM, genital urinary symptoms of menopause,
Okay.
and a lot of that can be prevented from topical estrogens.
Okay, that's helpful. Yeah.
Yeah.
Someone
Yeah.
might be like a mind body convert and might not think they should ever do anything, with creams or exercises. And these things can still be useful when you understand the
Yes.
system and the chemistry.
Yeah.
Um,
Whether taking oral or patch, that's a whole different scenario that needs to be individually decided between their team. But the topical, I feel pretty strongly that that's important.
nice. One thing I
Yeah.
wanted to touch on is, we talked a little bit about prenatal, postpartum, pregnancy, and I work in pelvic health, so I see
Yeah.
people have pelvic floor pain and dysfunction. Often the brain seems to create symptoms in a part of the body that makes sense. They're like the just to kind of anthropomorphize the body or the brain in this way. The brain is sort of thinking, I just rode my bike 10 miles yesterday. That it would make sense for pain to be there. And then the pain stays there. Or I've been riding my bike a lot. Or I'm pregnant right now. So, of course, there's a lot of pressure down there. Or there is a connection to some sort of activity or life circumstance and attributing it to the actual region of the body versus other factors that are causing it. And that makes sense that we would do that. How do you feel about that? Because I mean, I see it all the time.
Yeah. Because it's so hard to imagine that anything else would be the cause of something in that area, right? So it's easy to go, oh yeah, when I fell on my tailbone when I was 5 years old,
Yeah.
that's the cause. Or I'm like you said, ride the bike, or I sit at work for too long. So I think that's just the natural part of being human to find the causes of things in the pelvic area. But then when we talk about, because then we could talk about the spirituality component that is the first chakra, and this first chakra has to do with safety,
Mhm.
and then talk about possible reasons why the nervous system hasn't felt safe. That can be a gentle approach towards maybe it's not the physical cause, or the brain is very cautious and interested in the areas of the body that keep us survive, keep our survival of the self and survival of the species. So it makes sense that the brain's going to care more about where we urinate, defecate, and procreate, right? So
Yeah.
that's a way to talk about the sympathetic nervous system, the parasympathetic nervous system, and how heavily the brain cares about it. So sometimes that's a way to kind of help them lean into a bigger look at different causes than just the physical.
Definitely.
How do you like to approach that
Oh, yeah.
question?
I mean, I wrote a chapter in my new book about this, and it wasn't that we know exactly why neuroplastic symptoms show up in a certain region of the body because we still don't really have perfect evidence for that. But I have different
Right.
things in there, such as the energy centers of the body, also known as chakras. And
Yeah.
there's evidence that certain, statements such as safety or survivalism or sexuality,
Yeah.
the balance or imbalance in one of those areas, it can show up physically. And we have things like hereditary or DNA. You have this, not even just specifically, but you might think, oh, this is hereditary in the family. My dad had urinary issues. And so there can be a bias again coming from that. We can have symbolism. I mean, literally, you stop getting erections because you really don't want to be with your wife anymore and she mistreats you, as an example. You can have like a symbolic location that something shows up.
Yes. I
Importance.
think anger and being pissed off is
Yeah.
one that, is the symbolic connection to the bladder issues as well. Yeah.
Okay. That's interesting.
Yeah,
Yeah.
exactly.
But yeah, there are various possibilities. And like you said, the importance. I mean, the guys that I work with, oh my gosh, they have anything going wrong in their penis, their pelvic floor area, they jump to fix that. They do not do that with headaches or something with their elbow or like, no. There's a very high priority. There's like, this is my manhood, this is my sexuality, and they get really scared. They get really freaked out about.
Yeah.
And I think it happens with women too. I almost think that men almost react faster though to some of their sexual
Yeah.
things. That could be a generalization. I don't know.
Yeah. And I think I've had one patient tell me that because they had different things, right? A lot of them will have the migraine and the neck pain and TMJ and hip pain. And then the pelvic floor comes. And then that's when they start to say, okay, something's really going on. So it takes a pelvic floor to really help them take a look both outward and mostly inward at really what's causing
Yeah,
all these symptoms.
exactly. Because
And fear. It causes all the fear.
the fear too. Yeah. And fear can create the pelvic floor issue.
Mhm.
So,
Definitely,
of course.
definitely.
Um,
Yeah.
One specific question that, because women ask this, and I thought it'd be great to ask you about pain with sex or returning to intimacy. Maybe they are starting to relax some of the pelvic floor tension. They've had fear around it because it's created pain and discomfort. What's a good approach to kind of returning to intimacy?
Yeah. That's so important and such a great question. Because I feel like, again, the first thing I want my patients to know is that they're not broken and that sex is much more than a physical act, and that intimacy, you want to look at the reasons why they want to return to sex. Is it that because I want to fulfill my role as as a wife, that fulfillment of other duties? Or I had one patient say, well, I feel sorry for my husband. And I want to say, well, what about you? You deserve to sense and feel pleasure as well. What do you want? So that's number one, is really have them look at the reasons why they're ready to return and how we can decrease the fear towards that. And so for some, it's just talking about it, and they don't need any internal pelvic floor therapy, anything. They just need to recognize that recognize the reasons they had trouble having just for any or pain with intercourse, and the reasons they want to return, and that they are not broken and they deserve to have pleasure. Once we're on that, then some may need more, I call them positive corrective experiences with, let's say, the dilator, which is some tools we can use to help them not feel the pain and mainly not feel the fear. And then that can help them as they feel less fear, then they feel more prepared to have actual penis and vagina intercourse.
Yeah.
And then also the whole time we're talking about how can you find intimacy in other parts of your body? And it's kind of like somatic tracking.
Mhm.
Um, in a we don't want to be so disconnected when we somatic track, but we want to be able to just be with the sensations and feel the sensations when they're with their partner, as well as with maybe different tools that they may feel comfortable with.
Nice.
Yeah.
This is something that happens a lot with my clients is, I'll tell them it's safe to have sex. It's safe to masturbate. It's actually a good idea to do it. You don't necessarily have to overdo it, but you don't want to underdo it. Like start removing the fear, but then they do
Yeah.
have a flare up. My symptoms felt bad. And they're like, I know it's my brain's creating it, but it hurts. Like, I don't want to have sex again. Like, I want to, but I don't want to. And I kind of got caught in this back when I had pelvic pain too. How do you guide someone around that? Because, they might even intellectually think it's safe to have sex, but it literally is making them feel worse when they do it.
Yeah. Yeah. And there's nothing like libido, like pain with sex to decrease libido too. So it's all gets interconnected as well. So we have to, I like to use analogies. It's like we're training for a marathon, right? And you don't just run a marathon. If I just ran a marathon tomorrow, I'm going to feel flared up and hurt. So then that's where we kind of take it back and start doing little training runs. And that can look different ways with depending on the individual, but that's where I feel possibly the dilators can be helpful, or just working with a partner in different ways can be helpful.
Mhm.
And then as they have more positive corrective experiences, then the soreness and pain afterwards isn't so bad. But then also be able to sit with we'll call it the flare up after, and not feel just because of the flare up doesn't mean they re-damaged any tissue, or that this is not something they can return to.
Yeah.
That they can somatic track their symptoms afterwards and become less afraid of the after intercourse possibility of pain.
That's important, yeah. It's
So,
just like
yeah.
anything else in life, being able to be with what is there in the moment without
Yes.
labeling good, bad, go away, stay, is what helps it pass
Right.
through, and you're breaking the neural circuit pattern that has been reinstated over and over again.
Exactly.
Yeah. And
Exactly.
you mentioned you were gonna guide us through a somatic practice today in some way. If you'd like to, I'd love to be a part of it.
Yeah. If we have time,
We do,
I
yeah,
I
go
do.
ahead.
There's so many different ones, and you have some great ones too. I have one that's just short and quick, and then we can just do that. All right. So let's, wherever you are, just take this a moment to be present and just maybe start. Let's put your hands on your lower pelvis and sense the warmth of your hands on your pelvis, and just the gentle support your hands are giving your pelvis. And slowly begin to inhale and exhale. And with each inhale, imagine a warm, soothing light coming into the pelvic area. And that flow of light is bringing messages of safety, peace, and calm and healing. And with each exhale, imagine any tension or holding patterns or softening and releasing. So just imagine that pelvic bowl as you're breathing, filling with that warm light, and sitting there, that light is creating space and expansion for an area that is a center for vitality, it's a center for grounding and safety. And if it's comfortable, you can even bring some words of appreciation or a mantra. My pelvis is safe, or my pelvic bowl is safe. I trust my healing process. Or things are going to be okay. You just follow that breath a few more times, dropping into that light. And then when you're ready, you can open your eyes, wiggle your toes, coming back to the present. I like to use light a lot in my visualizations. Yeah.
That was really nice. I'm feeling even better. I'm feeling lighter,
Yeah.
feeling lighter. Thank you.
Yeah.
Thank you for that. And yeah, this was a really great conversation. We really appreciate you, Terry, for sharing your wisdom, your knowledge, and we'll link up some of your info below. If someone wants to reach out or
Yep.
get in touch in some way. Any
More than
final
happy.
words, like a final send off to everyone today?
Oh, yes. Just to know that you're not alone and to remain curious.
Beautiful. Thank you so
Very
much.
simple. Yeah. Thank you.